Good afternoon, everybody. My name is Ginny Edwards, and I'm currently Vice Chair at West Herts NHS Trust. I'm also a trustee of the Infection Prevention Society, and I have my own business as well. And at the time when we were reducing healthcare associated infection in the team, I was head of targeted support. Thank you, Tara and Sally. Really interesting to hear your reflections, because of course you don't often get the opportunity to meet colleagues and people you've known before and to hear what their view was. So I'll try not to cover too much about what they've said and skip through some of the slides. But perhaps maybe I'll start off by saying that this was very, very tricky because, as Tara said, it was, you know, headline news, but actually the microbiologists, by and large, thought we were focusing on the beginning at the wrong thing. They thought we should be doing C. difficile, that we shouldn't actually be doing MRSA at all. There were, in their view, quite small numbers. 7,000 in a year was not considered huge. And in fact, the original thought was that, you know, if we could get to 30%, that would be just fantastic. Nobody actually knew what could be achieved. But John Reid, who was Secretary of State for Health at the time, was very uncomfortable about that. He wanted 50%, and in fact, I think perhaps Sally might be able to tell us, but I think he wanted 50% of everything. So whatever target we were talking about, it was 50%. So that was, you know, it was a finger in the air, and nobody had any idea at all. And in fact, there was a big leak all over the press in 2007, which said that the target wasn't going to be achievable. And as Sally explained, there was, you know, a huge effort put into relooking at the strategy, plus quite a substantial additional amount of money that came in for the programme, which enabled us to do a lot more support. Next slide, Rich. So as Sally said, it was a, you know, it was a Prime Minister priority, a Secretary of State priority, and also was something that was across the whole of the department. I think we can go to the next one, and probably the one after that, Rich. So, you know, that quite a lot of thinking went into what do we actually need to do. And I'm quite, you know, a simple person, and I like to put things in nice little neat areas for me to kind of work out what to do. So these were the kind of 4 key things which colleagues have touched on, which was, you know, what was the best practice that was out there? And that sounds quite easy to say, well, you know, it was obvious, but actually at the time it wasn't obvious. There was lots of evidence about what might be the best practice, but we had to go and work out what the best practice was, and that went into saving lives. Raising the profile, I put here with NHS managers, but Sally's already, you know, mentioned about huge amount of stakeholder engagement in terms of thinking about what they all individually needed to do and could contribute. Supporting organisations to actually implement all this best practice, and I'll talk a bit more about that in a moment. And having improvement teams that went out to support organisations was the kind of 3rd box, and the 4th one was performance management. And it was, at the time, you know, we kind of moved away from this performance management, and I've left that word there because, you know, we've now moved on to performance improvement, but it was pretty tough performance management that went on around that target at that time. Next slide, please. So some of the things that we learned and we know was that you need clinical and managerial leadership at every level of the organisation. And Tara's already talked about out of the Health and Social Care Act and the Hygiene Code came the requirement for boards to have directors of infection prevention and control. And we were really keen that the word prevention should be there. You know, it's no good, you know, shutting the door after the horse has bolted. So actually we were really thinking about prevention before we got to the control element of it. How did we understand, you know, what individual accountability and ownership, you know, and that went from patients also washing their hands, staff washing their hands, and all the other bits up the system, what they needed to do. Really focusing on the data to drive improvement, really good antimicrobial prescribing, and the importance of screening and decolonisation, and a really a zero tolerance. You know, how do you create that kind of zero tolerance to people not actually complying with best practice, and the implementation of root cause analysis to improve practice, and from the whole improvement methodology, really thinking about how do you create this highly reliable system where everybody's doing the right thing at the right time for, and all the time. Rich, next one. So we came down to, actually there are really 4 key things that are helpful in terms of clinical practice about about hygiene. And that was, and I put it under HCAI, so it's kind of nice and easy to remember, which was hand hygiene, cleaning, antimicrobial prescribing, and isolation, and that also included testing patients as well. So those 4 became the key things that actually, if you look through all the guidance and everything that comes through the hygiene code, you can distill into those 4 things. If they're not happening, then you won't make improvement. Next slide. So what we found around clinical practice was that often there was a mismatch between intention and action. So people said, oh, I was wash my hands, but they didn't. People said they did training, but they hadn't actually really tested out whether there was competence. People had done hand hygiene back in the day, but then were too embarrassed to ask questions about doing something so basic. And often there were elements of the practice that were carried out, but rarely all of it. And what we found was that you actually had to do all of it. You couldn't just pick one of those 4 things that I was talking about and expect there to be improvement. You actually had to do all 4 of them, and that's what made the difference. Next slide. So this again kind of, we distilled this into 4 Ps for healthcare associated infection improvement. Was overarching, there was a Health and Social Care Act, and that was really, really helpful, because that set out the whole kind of policy statement around what was the expectation of organisation and leaders around this agenda. Understanding all those policies, and finding the right policies that would give people guidance around what they actually needed to do. Then the actual people themselves, putting it into roles, into job descriptions, training and competency and responsibility. What was the performance? Did you understand your numbers, what you were trying to achieve, where you'd got compliance, what your expected improvement was, and then how did you know that you actually had compliance against these policies? So where was your understanding around that? And then that whole kind of zero tolerance to infection being the mantra about what every organisation should actually set as their ambition. Next slide, please, Rich. So I think I've probably gone through that. So the biggest thing that I would say is that made a really big, the big difference was the whole kind of cultural change. So I put this under 4 Bs, again, because it is a kind of framework that I find easy to use. So the first one's belief. So if you don't believe that you've got a problem, if you don't believe that there is a solution, then you aren't going to do anything about it. So one of the key things that we did was we went to each of the organisations and we insisted that we had a meeting with the chief executive, the finance director, the director of nursing, and the chief medical officer, and actually put together a whole pack which actually showed them their information about them, about where they were within their group of hospitals, about what their peer group looked like, and what we thought was the opportunity for improvement. And getting the leadership on board with actually understanding and believing that they'd got a problem. Actually, we had the chief microbiologist there as well, or whoever was in charge of microbiology, and getting them to really buy into the fact that actually we have got a problem, we have got an issue, and we need to do something was key. If you haven't got the leadership engaged, then actually you were going to get nowhere, because we knew there was infection prevention control teams out there doing really, really good work and trying at grassroots to make improvements, and they were just getting nowhere. So, you know, we knew that was important, and we knew it was important to really direct those folk what they needed to do. Then you're talking about what's the behaviour change that you need, and I can talk more about that. That's about hand hygiene and all the other things that I've talked around, antimicrobials. And then how are you sure that those things are really happening? So that goes back to what do we need to know about compliance, and what will help us to know that we're doing the right thing. And the last thing is be helpful. So I was absolutely sure that I wanted the targeted support teams to go out there and be helpful, and not to feel like it was punitive, and that people were going out there just to catch them out and tell them that actually they were doing the wrong thing and they were being told off, and that we actually were helpful. And in fact, we did go to every single NHS trust, bar one in the whole country, and do a review and provide targeted support and help. Next slide, please. So these are just around some of the numbers, and so we've now got 89.5% reduction from the 2003-2004 baseline, which is slightly higher than the original target, and that's been sustained. And I think that's the thing to be most proud of. Is I've been involved with lots and lots of change management, but actually sustaining the change and keeping it going is absolutely the hardest thing, and the test of your success, and not just the reduction. So last slide, just some things to think about. So C. diff was added, and we've seen a great improvement in C. diff numbers as well. But we also had a hypothesis that methicillin sensitive Staph aureus would also come down. This hasn't happened, and we don't exactly understand why. And a lot of that goes back to what Sally was saying about really understanding community and what's going on in the community and how that all works. We spent a lot of time understanding what works. So the NHS is absolutely brilliant at hearing something this week and telling everybody next week they've implemented it, and not really understanding about the evidence and about what really works and how they should implement it. Fresh pairs of eyes are really useful. They do tell people things that they either don't know or they assume, but being supportive is the only way to do it. You need sustainable behaviour change. You require everybody in the system to be compliant. You can't just have odd folk. I put out of hospital was difficult. We did go and do some work in nursing homes, but it is really, really difficult, and there's a lot to learn. And of course, we all know now that the whole urinary tract infection and E. coli is a big issue, and trying to sort that out, which is mainly community acquired, is very difficult. And people, you know, say that, oh, couldn't we just take the learning from for this program and just apply it elsewhere? If there are, and MRSA is not simple, but if you can find simple things to change where you've got the evidence, where you can actually assess compliance, and you can build that cultural change, you can apply it elsewhere. But a lot of what is going on in healthcare is very complex, and it's not necessarily easy just to transfer all the learning from one to another, but there are some transferable things that we can learn. So I'm looking forward to having a chat with you all about it. Thank you.